Once again, welcome back to obstetrics and gynecology videos. Today we are going to see about cesarean section. If you are looking into the history, we can see that the first cesarean delivery was the delivery of Julius Caesar. Before 20th century, that is in 19th centuries and all, actually the cesarean was a fatal condition. In majority of the cases, it used to end up with the death of the mother. Because anesthesia was not established, and without giving anesthesia, they used to operate the mother's abdomen to save the life of the baby. But nowadays, the cesarean has become a most common surgery. The definition of cesarean is the delivery of the viable fetus through an incision in the abdominal wall and uterus. If we are delivering a live baby by making an incision over the abdominal wall and uterus, then only we can call it a cesarean. If the baby is not alive, usually we won't go for the cesarean. And another thing, in case if the uterus is ruptured already, and if you're just performing a laparotomy and if you're taking the baby out of the uterus, that delivery we are not including under the cesarean. We know that nowadays the number of cesareans are increasing when compared with the olden days. However, think about the reason for that. One reason is increased repetition of cesarean. That is, in the previous delivery or in her first delivery, if it was a cesarean, in the next delivery also the chance for cesarean is more, because doctors will not take the risk, and even the patients also may not be ready to take a risk by trying for the normal delivery, and automatically that will go for the cesarean, second delivery or subsequent deliveries. That is one reason. Another reason is difficult instrumental delivery or vaginal lobes delivery. We know that if you are using forceps or vacuum for delivering the baby, it may produce complications for the mother and for the baby. In order to avoid those complications, nowadays the doctors and even the patients opt for the cesarean. And increased diagnosis of intrapartum fetal distress. Nowadays, due to the latest diagnostic measures and due to the latest investigation techniques, it is possible for us to diagnose the fetal distress in the earlier stage itself. And in that cases, in order to save the life of the baby, we can go for the cesarean. That is also an indication. And cesarean on demand. Nowadays, some of the ladies, they don't want to suffer the pain of normal delivery. So in that case, they will opt for the cesarean. And another reason is identification of risk for the mother and for the baby. During the pregnancy, at any time, if you have identified any risk factors for the mother or for the baby, in that case, naturally, the doctors will prefer for the cesarean. And the last one is increased pregnancy by in vitro fertilization. That is, we know that nowadays the number of pregnancies after taking treatment for a long period, it's quite common. In that cases, if it is a precious pregnancy, the doctors as well as the patients will not be ready for taking risk by trying for the normal delivery. So they need to have a safe delivery and they need to have a safe child. So in that case, the patients will opt for the cesarean and the doctors also will opt for the cesarean. The indications for the cesarean include history of previous cesarean section, because in the case of previous cesarean section, already if the mother is having a previous cesarean, in the subsequent pregnancy, during the time of labor, if you are trying for the normal delivery, there is a chance for rupture of the uterus. So for avoiding that, nowadays, in the subsequent pregnancies also, they will go for the cesarean. And dystocia or dysfunctional labor. Already we have seen in the previous videos what is dystocia, that is difficult labor. If there is any difficulty in labor, it may be due to the improper uterine contractions or maybe due to the contraction of the pelvis or maybe due to the large size baby, whatever is the reason. If there is a dystocia or difficult labor, in that case you can go for the cesarean. And another reason is fetal distress. During the course of labor or during the time of pregnancy also, at any time, if fetal distress is developing, you can go for cesarean in order to save the life of the baby. And breech presentation. In the case of breech presentation, normal delivery is possible, but in order to avoid the complications and to avoid the risk, nowadays people used to go for the cesarean. And another one is antepartum hemorrhage, bleeding or excessive hemorrhage before the delivery of the baby. In that case also we can go for the cesarean section. maternal problems. For example, if the mother is having eclampsia or gestational diabetes or any other serious conditions are there for the mother, in that case also you can go for the cesarean section. And cesarean section on demand. Already I have told you about that. If the mother is preferring for a cesarean or her family members, if they suggest a cesarean section, in that case also you can go for the cesarean. Now we can see the types of cesarean. According to the timing of cesarean, it can be classified into emergency cesarean and elective cesarean. If it is an emergency one, that is if you have diagnosed fetal distress during the process of labor, or if any unexpected situations are coming, and if it is producing danger for the mother or for the baby, in that case, if you are going for a cesarean, that is known as emergency cesarean. And elective cesarean means already the date will be fixed by the doctor and by the patient. It may be on due to the demand of the mother, or it may be a precious pregnancy. In that case, you will plan earlier for the cesarean, and a date also will be fixed. Everything will be arranged and you will go for the cesarean. That is known as the elective cesarean. And according to the site of incision, we can divide the cesarean into lower segment cesarean section, classical cesarean section, and cesarean hysterectomy. Now we can see about the lower segment cesarean section or LSCS. Nowadays, this is the common cesarean we are performing, that is LSCS. In the LSCS, first we should see the pre-operative care or the preliminary arrangements that we are supposed to do before a cesarean. In that, first one is we need to arrange a cross-matched blood. A catheter should be introduced into the bladder. Prophylactically, we should start antibiotics for the mother, and heparin or thromboprophylaxis should be given. Parts cleaned and with the antiseptic solution, that is abdomen and perineal area should be cleaned. It should be shaved and cleaned well with an antiseptic solution. And you can give a lateral position in order to reduce the aortocaval compression and to reduce the suppression of the compression of the inferior vena cava. Aortocaval compression, the gravid uterus, if the mother is lying in the supine position, the gravid uterus or the large pregnant uterus will compress the inferior vena cava, and that leads to decreased cardiac supply, and that leads to decreased cardiac output. By that way, even the blood supply to the fetus also may decrease. So in order to avoid that, give a lateral position for the mother. Next is the anesthesia we are using for the cesarean. We can use even general anesthesia or regional anesthesia. In the regional anesthesia, we can go for the spinal or for the epidural. But the complication of general anesthesia include the Mendelssohn syndrome, that is aspiration of the stomach contents, that is especially the acid contents. It will go into the respiratory tract and it will produce a chemical pneumonitis. And for reducing that, in order to counteract the effect of this Mendelssohn syndrome, before posting the case for the cesarean, you can give antacids and you can restrict the oral intake. Antacids 30 ml sodium citrate orally, you have to give half an hour before the surgery. And you can go for the Celic's maneuver also, that is during the endotracheal intubation. Before giving the GA, we know that we will do the ET tube intubation. We will insert the ET tube. When you are inserting the endotracheal tube, what you can do means you can apply pressure over the cricoid cartilage and it will close the esophagus. Through that way also you can prevent the regurgitation of stomach contents into the respiratory tract. And now we can see the comparison of transverse incision and vertical incision, that is comparison of lower segment cesarean section and classical cesarean section or vertical. First one is cosmetic appeal. In the transverse cesarean section or in the case of lower segment cesarean section, the cosmetic appeal is more. But here the vertical incision will be there over the abdomen vertically, so the cosmetic appearance is less. And if you are going to the postoperative pain, in the case of LSCS it is less, and in the case of vertical it is more. And if you are going to the wound approximation and wound dehiscence, the chance for wound dehiscence or separation is less in the case of lower segment cesarean section, and it is more in the case of vertical incision, because when you are moving or when you are changing the position, there is a chance for stretching of the wound edges due to the pulling of the muscles, and that may lead to the separation of the wound. And the incisional hernia, there is a chance for incisional hernia after the delivery. After a long period, there is a chance for incisional hernia, and this chance is more in the case of vertical incision and it is less in the case of lower segment cesarean section. And technical skill, the doctors need more skill in the case of lower segment cesarean section, and in the case of vertical, that much is not needed, that much skill is not needed. And the time taken for the cesarean is more in the case of transverse or in the case of lower segment cesarean section, and it is less in the case of vertical or classical cesarean section. And the access to upper abdomen, it is less in the case of LSCS and it is good in the case of classical cesarean section. And now we can see how to perform the lower segment cesarean section. First we are supposed to make an opening or put an incision over the skin, over the abdomen, that is in the lower area, lower segment, portion of the uterus, in the lower part of the abdomen, vertically, transversely we will make an incision, and we will make an opening in the abdomen, and dextral rotation of the uterus, if it is there, it should be corrected. And after making an opening, insert the Doyen's retractor. Visualize the lower segment of the uterus properly by inserting the Doyen's retractor, and peritoneum over the lower segment should be identified, and divide it transversely and separate it from the bladder by a blunt incision, and put a small incision over the lower segment of the uterus and extend it laterally. And if the space is not adequate, you can extend it in a J-shaped manner or in a inverted T incision, and you should take care in order to avoid injury to the uterine vessels. And next is delivery of the baby. You have opened the uterus and all the layers of the abdomen. Next is delivery of the baby. If it is a cephalic presentation, slip the hands into the uterine cavity and elevate the head gently, floating the head. If it is a floating head, you can use forceps for delivering the head. And if it is a breech presentation, you just hook the feet of the baby, hook out the feet of the baby. Rest of the body can be delivered as like in the case of breech delivery. And in the case of transverse or oblique lie, first you just correct the lie before making a uterine incision. And in the case of transverse lie with ruptured membranes, or in the case of undeveloped lower segment, extension of uterine incision will be needed. And next is the closure. Once after the delivery of the baby, we are supposed to close the uterus and abdomen. Before closing, you should start oxytocin soon after the delivery of the baby. And once if the uterine fundus is contracted, you can deliver the placenta and membranes. After delivering the placenta and membranes, wipe the uterus with a moist pad and ensure that the uterine cavity is empty, and remove the contents from the cervical canal and make sure that the cervical canal is also open, and suture the uterine edges by holding it by using Alice or green Armitage forceps, and the layers will be closed in 2 layers. Uterus will be closed in 2 layers by using continuous suture. And for suturing the uterus, you can use a chromic catgut or polyglactin. And if any bleeding site is there, means it should be controlled by suturing it by using the figure of 8 sutures. Next is closure of the abdomen. Close the peritoneum and go for the rectus sheath. For the rectus sheath, if you want, you can use the non-absorbable suture, but nowadays commonly we are using the absorbable one only. And non-absorbable means if we are using proline, it will help for reducing the wound dehiscence and incisional hernia in the future. And later we should close the subcutaneous tissue. And finally, when we are coming to the skin, we can suture the skin by using the Marta sutures of silk, or by subcuticular suture, or by using the clips. Next is the postoperative care in the case of lower segment cesarean section. It is more or less same even for the other types of cesarean also. Close monitoring is needed in the first 6 to 8 hours, and parenteral fluid should be given, and blood transfusion should be given if needed. Give analgesics and sedatives for the mother. Slowly, after 6 hours, you can start the oral fluids, and early ambulation is needed. It will help for the proper contraction of the uterus, and you should allow the mother to practice the deep breathing exercises immediately after recovering from the anesthetic effect, and from the next day onwards she can go for the circulatory exercise. Gradually she should start to do the postoperative exercise also. And light solid diet should be given initially. Along with that, you should give laxatives also in order to prevent the constipation, and discharge the mother after the removal of the suture. If it is a subcuticular suture, you can discharge her on the 5th or 6th day. And the advantages of LSCS is already we have seen, but once again we will discuss about it. In this case, the healing is better and the scar rupture is minimal when comparing with the classical cesarean section. Next, lower segment vertical incision. In some cases, after making a lower segment incision, sometimes we may make it as vertical. The indications include constriction ring, or if the lower segment is not formed. But the disadvantages include it may produce injury to the cervix, vagina or bladder. There is a chance for rupture of the uterus in the subsequent pregnancy. Now we can see about the classical cesarean section or vertical incision. The indications for the classical cesarean section include if the lower segment is unapproachable, or if cancer cervix is there, or if the placenta is located in the lower segment of the uterus, or if there is a history of previous cesarean with the same classical incision, and if there is a transverse lie with the ruptured membranes, and if conjoined twins are there. In these cases, we can go for the classical cesarean section. And the disadvantages of the classical cesarean section include difficulty in healing. There is a chance for scar rupture and chance for peritonitis is also there. Next is caesarean hysterectomy. In some cases, along with the delivery of the baby, we will do the removal of the uterus also. We will remove the uterus also. The indications include if the mother is having severe atonic postpartum hemorrhage, or if severe placenta accreta or increta or percreta is there. Already these things we have seen in the previous video. If you are having any doubt, you can go for the placenta accreta. That video, it is there separately. And if there is severe sepsis or infection, if there is large myomas or tumor inside the uterus, if there is cancer cervix, in that cases you can perform the hysterectomy also along with the cesarean. Now we can see the complications of cesarean section. These complications can be of intraoperative, that is during the operation itself some complications will develop, and after some complications will develop. So first we are going to see the intraoperative complications. That include primary hemorrhage, injury to the internal organs. Already I have told you that when you are separating the peritoneum, you should put an incision and you should separate the bladder. Otherwise, there is a high chance for injury to the bladder, especially in the case of lower segment cesarean section. And there is a chance for injury to the baby, chance for difficulty in delivering the head, and chance for anesthetic complications. Already we have seen Mendelssohn syndrome. That is an example for anesthetic complication. And another one is primary hemorrhage. Already I have told you. The primary hemorrhage can be due to uterine atony, or it may be a traumatic hemorrhage, or it may be due to the placenta accreta. And if it is due to the uterine atony, you can start oxytocin 20 units in 500 ml of solution, or you can give ergometrin 0.25 milligram IM or IV, or along with that you can give prostaglandin F2 alpha 250 milligram 250 microgram IM, or intramurally also, that is directly into the uterus also you can give it, or otherwise you can give prostaglandin E1 200 microgram rectally. And if it is a traumatic hemorrhage, you can suture the blood vessels, concerned blood vessels from where it is bleeding. And if it is placenta accreta, and if you are not able to remove, you can go for the removal of the uterus. And the post-operative complications after the delivery, after the cesarean, there is a chance for paralytic ileus, that is peristaltic movements will not be there, chance for respiratory complications. Already I have told you about the Mendelssohn syndrome, chance for infection, peritonitis, pelvic abscess may form, there is a chance for thrombophlebitis, deep vein thrombosis and pulmonary embolism, there is a chance for wound dehiscence. And later, after 6 days, there is a chance for secondary postpartum hemorrhage, chance for incisional hernia is there, scar endometriosis chance is there. There is a chance for vesico-vaginal fistula. Vesico-vaginal fistula means it is the connection between the vagina and the bladder. So what will happen means involuntarily, continuously the patient will be passing urine through the vagina. There won't be any control for the passage of urine. And scar rupture in the next pregnancy. In the subsequent pregnancy, there is a chance for rupture of the uterus. And chance for placenta previa and placenta accreta. In the subsequent pregnancy, sometimes the placenta may get adhered to this sutured areas. And if it is getting adhered to the sutured area, there is a chance for deep inversion, and that may lead to the placenta accreta also. And another one is chance for bladder injury. So that's all about the cesarean section. I hope you understood the video. Thank you for watching this video. See you once again with another video.